about the great team that I work with at HSD, because that needs to be on the recording. But you can see from our first slide here that our mission is to transform lives working with our partners. We design and deliver innovative, high quality health and human services that improve the security and promote independence for New Mexicans and their communities. And this was one of the first goals, projects that we worked on in this new administration, was to modify, update the mission for HSD and establish the 4 goals that you see in front of you. And we live these goals and missions every day. So I will now be able to let Nicole talk to you a little bit about Medicaid. I'm hoping that we address all of the topics that you all presented to us. So we will go over our Medicaid waiver, some, enrollment innovation activities that we're doing. We're going to talk a little bit about behavioral health and our justice involved programs, and then we'll open it up for questions. So Nicole, do you want to take it away?
Sure. Thank you, Angela. So I just want to echo Angela's sentiments to all of the providers. Just thank you all so much. I know how hard this has been on our teams and our staff, and I just can't even fathom how tired you all must be at this point. And so thank you for your continued service to all of us here in New Mexico. So I do have some folks with me who introduce themselves. Medicaid is a behemoth. And so there are parts that I have had the time to dig in deep, but there are certainly many others where I rely on these subject matter experts to really support us. So I am actually going to cover the waiver section, but as we get through the presentation, I will probably defer to Kathy and Abuko to jump in with additional details about a couple areas. And then finally at the end, I'm going to wrap up. Looks like folks are asking for the presentation, Angela, so we'll just send that over. At the end, I'm going to wrap up with some reproductive health equity slides. And then I know that Kaylee sent over some additional questions that came in a little bit later, which we also completely understand. And so those are not included in the slide deck, but we'll do our best, excuse me, to address them. And if we need to take anything back, we'll just continue to communicate with you all. I hope that this, like Jane already said, will be a running dialogue. I think there's some really great things that the team has done here in New Mexico, but I also know that there's a lot more we could be doing. So really looking forward to all of your input on and suggestions about how we can continue to run the program better and make sure that we are addressing all of these issues. So starting out, there was a question in particular about the 1115 Medicaid demonstration waiver. And this is a pretty experienced panel of folks here. So I won't go too far in the weeds, but just for those who aren't as familiar, Medicaid programs are obviously jointly run by state and federal government. And the way that we operate is usually under what is called a state plan amendment, sorry. And then there are many state plan amendments as the program evolves. But CMS, the Centers for Medicare and Medicaid Services, approve those state plans. And those are kind of the plans that are normal course of business for Medicaid. They're things that CMS has already approved, parts of the program that are codified and have been outlined in statute. 1115s are waivers that allow us to essentially experiment a little bit. So there's the normal kind of within the box things that you're allowed to do in Medicaid, and then there's opportunities to try out other things and serve different populations in different ways. And so that's exactly what this waiver does. And folks had asked about the substance use disorder waiver efforts that are underway. So we wanted to include this information. Again, I'll say this at a high level, and then we've got folks on to answer questions as well. Abuko, I'm realizing that we're missing Annabelle, who was going to potentially help. So if you don't mind forwarding her the appointment, just to double check. So 1115 demonstrations are approved for a 5-year period, and they can be extended for up to an additional 3 to 5 years, depending on the populations being served. We currently have an 1115 waiver in place, and it is approved from January 1st of 2019 through December 31st of 2023. On May 21st of 2019, the Substance Use Disorder Implementation Protocol, and we'll just call it SUD going forward, as required in the state's 1115, was approved. So there's quite a few parts to this SUD effort overall. There's the waiver application that we submitted, and then there's an implementation protocol, and then there's also a monitoring protocol and an evaluation as well. Our 1115 waiver application supports and focuses the SUD evaluation. So actually looking at how this kind of experiment, for lack of better words, is working under the Medicaid program. And it's focused on these 6 goals that we developed and had approved by CMS. So you can see, in coordination with CMS, I should say. So you can see those 6 goals on the right hand side of the slide. And the goals are to increase rates of identification, initiation, and engagement in treatment for opioid use disorder and other substance use disorders. Increase adherence to and retention in treatment for OUD and other SUDs. Find reductions in or create reductions in overdose deaths, particularly those due to opioids. Reduced utilization of emergency departments and inpatient hospital settings for OUD and SUD treatment, where the utilization is preventable or medically inappropriate, through improved access to other continuum of care services. Fewer admissions to the same or higher level of care, where readmission is preventable or medically inappropriate for OUD and other SUD. And then finally, improved access to care for physical health conditions among beneficiaries with OUD or other SUDs. And I promise not to read you slides for the rest of the presentation, but the goals are pretty specific and wanted to put those out there for you all. So there was a question about public input and if folks could weigh in on these 1115 demonstrations in the future. And so we absolutely would love to have all public participation in this effort. As you can see here, this 1115 for SUD was actually already approved. And so the next time that we would go through a formal public comment period will be in December of 2023 when it's up for renewal. But in the interim, there's certainly opportunities for engagement. And I think that we can keep that dialogue, like we said, open with this group to let you all know how our progress is going on this front and provide updates on the program overall, so that there's additional opportunities for public engagement. So Angela, if you can move to the next slide, please.
I am trying here. One moment, please.
Looks like my internet really does not always hold up, so it could be me. But while Angela is trying to switch over, what we wanted to make you all aware of, because the opportunity for public input is right now actually on what is an 1115 waiver amendment that we're working on. It's not specific to the opioid program, which you all asked about in the questions that were sent over to us. But I did think that there may be some pieces of this that you all may be interested in. So we are working on this amendment currently, and there are 3 pieces listed here, but given a rule that came out from CMS last night, we'll actually be adding another piece to address vaccine coverage for COVID vaccine administration. And I saw that some of the questions that came over from Kaylee just, I think either today or late yesterday, spoke to that vaccine implementation. So I'll address that in a moment here. But the 1115 that we're working on has 3 parts that were previously identified. The first of which is the implementation or expansion, I should say, of high fidelity wraparound services. And so this is for kids and an effort that we currently have underway, but in a smaller setting. I don't know if I'm missing a chat here. I hear dings. Okay, no. And that we're looking to, in the longer term, our vision is to expand statewide and outside of just children in custody. The next portion of the waiver amendment will be around serious mental illness and serious emotional disturbance, and expanding opportunities for placement for those individuals where appropriate and needed. This has been a challenge for the program. There's currently a limitation on how long individuals with SMI or SED can stay in an IMD. And we often find that there are families who are really struggling to deal with episodes with their family member from time to time, where having them in a community-based setting isn't always what's best either for the family or for the individual. And so CMS has begun allowing for this extension of stay in an institution for mental disease. So we are looking to adopt that exception that they put out. And then finally, graduate medical education expansion. This is something that's really important to the program, and I'm sure you all would have a lot to say about this as well. We have been working pretty extensively on doing assessments of our provider network here across the state. Have looked really closely, obviously, at behavioral health. The Behavioral Health Collaborative has done a lot of work there, and then more recently have begun a lot of work around the availability of primary care providers across the state. And so supporting additional graduate medical education is something that we feel is really critical to invest in. And so that will be included in this waiver as well. So the last piece that came about last night that we just talked about this morning that we'll be adding into this waiver, CMS released their rule that explains how state Medicaid programs will be expected to provide coverage for the COVID vaccine. Yes, we will, Jane. As soon as the public comment link is posted, we will share it with this group. Good question. They provided pretty extensive guidance to Medicaid programs around how we'll be expected to cover the COVID-19 vaccine once approved, or vaccines potentially. There are a number of instances in which when the public health emergency declaration ends, there will be subsets of the eligibility categories that we cover in Medicaid that we won't have an avenue to provide actually coverage for the administration of that vaccine unless we submit a state plan amendment, or if we submit an 1115 waiver. So in particular, limited benefit categories in Medicaid, so family planning being the best example. Those individuals, we don't normally cover vaccine administration for outside of those associated with family planning. And so we will have to submit an 1115 waiver to make sure that we have the ability to provide reimbursement for services for those individuals. So we'll be adding that in. At the very end, when we get through all of the other questions listed, I'm happy to provide some additional information on that new guidance that came out and try and kind of look at it through this lens of racial justice as well. Okay, so I think I saw a question pop up that was related to this. I believe that I heard that the GME expansion does not include graduate level behavioral health providers. Is that correct? I don't think that we have Alex on with us, who is the lead on this program. Angela, do you know off the top of your head, or Neil?
Yes, I do, actually. GME is the 3-year residency program after doctors have graduated from medical school. And so, no, they do not include behavioral health providers per se. There is mandatory behavioral health training involved in all 3 years with behavioral health faculty there. So it is an expansion in some sense and there's a mandatory training in being integrated with behavioral health, which is fairly new in ACGME. I think it came on board about 7 or 8 years ago. So it's not directly training behavioral health providers, that's absolutely correct, but it does improve the training in behavioral health care for our primary care providers. And then I think there are 2 programs that they're trying. They're not primary care graduate medical education, but psychiatric graduate medical education. So that would increase the behavioral health workforce.
Thank you, Neil. Okay. So we are getting ready to submit this 11/15, and so there will be a public comment period coming up likely January 1st through January 31st, as long as we are able to keep on track with our tight timeline here and lots of other things going on. So Jane had sent a comment across and asked if we'll share that link when it's ready, and we will make sure to do that.
Just a quick question.
Yes.
This is Anjali. What does it practically mean, just out of curiosity, in practicality, what does it mean to have a 1115 waiver for GME? And then in practicality, what does the 1115 waiver for substance use disorder give New Mexico and Medicaid more resources for? What? And I'm just unclear on that.
Sure. So you're just asking, like, what are we doing that's beyond the norm of what is allowed through the Medicaid program by utilizing these waivers?
Yes. Yeah.
Okay. So Neil, I don't know if you want to speak to the GME piece, and then I can do the SUD, or if you want to jump in there as well.
Sure. So I'll do the GME piece, and okay. What it allows is for there's Medicaid subsidy for individual residents. And this would expand the ability to pay for 10 more residents per year through Medicaid, which reduces the burden on the state general funds for having this graduate medical education program.
Okay, thanks, Neil. And then on the substance use disorder, it allows us to target a population and target resources from the program to try to reach these goals that we've outlined, and then determine if the way that we're utilizing those Medicaid funds is effective, so that we can keep spending the dollars in that way. That's the evaluation component outside of how we would normally pay for services.
Thank you.
Mm-hmm.
Are we ready to move on, Nicole?
Yes, thank you. Sorry, I have my notes up on my other screen, so I'm talking to you all, but I've got the dual screens going here. Thanks, Angela. Yes, we can go ahead and move forward if there are any other questions about the 1115 waivers. And again, we will make sure to keep you all engaged with us as we move forward on both of those waiver efforts. Okay. So Medicaid justice involved utilization of state transitioned healthcare. So Kathy, I was actually going to kick this off, but I think I will turn it over to you if you are good to go and walk through these slides.
Sure, I'll take it.
Great.
So it is the longest name program, but the best acronym, Just Health. This involve utilization of state transition healthcare. So Just Health allows New Mexico Medicaid to do a few things. In Medicaid, we are not allowed to pay for coverage for someone who is incarcerated other than a 24-hour stay, inpatient hospitalization stay. That's the only thing that that is allowed per federal rule. So to make sure that we could do that, we started our short-term Medicaid for incarcerated individuals program, and that allowed us to implement the short-term coverage for those inpatient stays. That was in 2014. In 2015, we had Senate Bill 42 introduced that would actually help us and did help us extend our justice involved program. We were allowed to have applications taken while people are incarcerated. And the overarching goal for Just Health and Senate Bill 42 was really to make sure that people had access to care when they were released. Before Just Health and before Senate Bill 42, when people were incarcerated, their benefits were cut off. They ended at the date of incarceration. We have defined an incarceration stay as 30 days or more. And now with Just Health, we do not close Medicaid, we suspend the benefits. So the individual remains eligible for coverage, but they don't have access to their Medicaid benefits while they're incarcerated. But what that has helped us do is when they're released, we can reinstate the benefits at their point of release. A Medicaid application can take up to 45 days to process. So that was a real huge burden for people when they were released, if they had to start the application process at that point in time. So now we are able to reinstate benefits and they have immediate access to care. We've tried to, we do a data feed with several counties and the corrections department that gets us that booking and release information. And we've also trained staff at those facilities as presumptive eligibility determiners. And presumptive eligibility is short-term Medicaid, basically. So someone who is in need of immediate care, we can grant presumptive eligibility if they meet all qualifying Medicaid factors. The PEDs at these, that's the presumptive eligibility determiners at these facilities, they don't generally grant presumptive eligibility. They do an ongoing application. When we first started the program, we had, I'll get into the numbers on the next slide, but we had a lot of presumptive eligibility determinations made, and not everyone received an ongoing application, which really kind of defeats the purpose of application assistance while someone's incarcerated. It would get the coverage for a short-term hospital stay, but it didn't guarantee them coverage upon release. So our numbers have gotten a lot greater. You'll see that on the next slide. As I said before too, we have a data feed that we get from corrections. And the problem we've been having is each county has their own system, and trying to link up our eligibility system with every county's different system has been a challenge. It's been our biggest challenge, I would say. So here we have some of our Just Health numbers. Again, the suspension and reinstatements are, you know, we get a booking date for an individual who's incarcerated, and after 30 days, those benefits are in the suspended status. When we first began the program, of course, our numbers were high for the suspensions, but I like the trend that we're seeing in 2020, where our suspensions are much lower than our reinstatements. That's exactly where we want to be, I think. We did do a little bit of math on the facilities we are getting numbers from. One of the questions that somebody had sent was, what is the percentage of people who are getting released with Medicaid in place? We don't get data from every county. We do get it from, we have a CYFD agreement, Department of Health Forensics Unit, Corrections Department, Bernalillo County, Doña Ana County, Rio Arriba, San Juan, Sandoval, and Santa Fe. Those are the counties we're getting, or the entities we're getting data from. But with those, our release numbers, we're over 90% of the people that are getting released from those facilities have Medicaid when they walk out the door. And there at the bottom, the STMI claims that $10 million is a huge amount of money of savings for the state. A lot of those are from, most of that's from our corrections department for the inpatient stays. And then the PE approvals, as I said before, and that first little bit of time, we had 1,300 of those. And since then, in the following 4 years, we've had 479. So, and out of those, 98% or something had an ongoing application approved. So that's it. Any questions on Just Health? There's something in the chat.
Yes, Kathy.
No.
I don't see any chat, but I do want to just reiterate what Kathy said, that this data is actually pretty incredible to see the impact that the changes are having in such a short time. There's a significant reduction in, like she said, that short-term Medicaid, and their coordination with the counties has really resulted in significant actual application increases. So really a huge achievement there. Are there other questions on this? I feel like there was one in the list that Kaylee sent.
This is an area that this group had a lot of interest in. One thing I wanted to ask, sometimes in terms of continuity of care and ensuring that people get set up for appointments if they have, for example, significant behavioral health needs or chronic conditions, are there particular efforts with the MCOs, the managed care organizations, to make those connections and links when somebody's re-entering the community?
Yes, I'm sorry. I should have mentioned that because it's a big part of our program. I had it on that first slide and I guess I skipped it over. So we do work with our MCOs extensively. We have a work group that has representation from CYFD, the Association of Counties, Corrections, and all of the MCOs. And it really was, we have been working to ensure a transition of care is in place for individuals when they're released. I have to say we were making great headway before the pandemic. So it sort of slowed our process down a little bit just because the MCOs were sending care coordinators into facilities to do that sort of warm handoff with the jail and prison staff. And it really was, it's really effective. And the MCOs have said that, that face-to-face contact is the way they're getting the most bang for their buck on that transition of care, that they're getting that follow through and follow up. They can maintain contact with those individuals long after they're gone from jail. And it's the most impactful, versus what they were doing on the phone, which is now mostly what they're doing for some of that. So does that answer your question, Jane? For the justice involved, there was a chat question. Are you compiling racial data to look for racial disparities? We have not been pulling racial data. It is something we probably could get if it's disclosed on a Medicaid application. We don't get the demographic kind of information or any kind of racial identifiers from the jails or prisons at this point. Corrections is the place we get a lot of our data, a lot of our releases. And honestly, they're in a paper process still at this point. So there's not a lot of information we get from them electronically. But yeah, it is something we could pull from the Medicaid side if it's been disclosed.
Yeah, it's something that I asked the same question, Margaret, when we were working on these slides with Kathy, is if we had it broken down by race. You may know this, but there are fields that we are and are not allowed to make mandatory in the Medicaid application. And this is one that we are not allowed to make mandatory. So the data that we do get is not complete often. So, but I think it would be worth absolutely us taking a look at how much we do have. And, you know, then we can see if there's other ways that we can get at it by using some of those other resources that Kathy mentioned.
Director Como, one other thing before we go on to behavioral health. The 1115 waiver does cover most enrollees in Medicaid, but there is a significant fee-for-service program. Native Americans may choose whether or not to opt in to managed care. And so do you want to just speak to the fee-for-service piece just briefly, just to give it many Native Americans access care in New Mexico through Medicaid?
It's true. And sorry, I hear noise in the background. So if you need me to repeat anything, please let me know. So that's true. The Native American population is able to choose to remain in the fee-for-service side of the program or to opt into the managed care side. In the past, historically, there has been a far more significant number of Native Americans in the fee-for-service side. But interestingly, and even most recently, during the months of the public health emergency, we have began to see a significant shift in that Native American population into the managed care side of the program. So on the managed care side, we work with the 3 managed care entities that were chosen through the state's procurement process, and that's Blue Cross, Blue Shield in New Mexico, Presbyterian Health Plan, and then Western Skies. And those 3 entities cover the vast majority of the program, like Jane said. We currently, we've obviously, you all have likely heard this, and it doesn't come as a surprise with the growing unemployment numbers, unfortunately, but we have seen significant growth in the program, almost 60,000 individuals since the beginning of the public health emergency. In March, before things really began to impact us here in New Mexico, we had about 837 enrollees in the program overall. We now have 891,000 individuals in Medicaid. That's 43% of the state. And so of that, the managed care population is about 80% of our enrollees total. So I think, you know, there's continued work to do there. We want to always make sure that services remain equitable between the 2 sides of the program. And so I think that's another area that we would like to continue to look as well. Jane, I don't know if that, you know, kind of got to the questions you were asking, or if there's anything else I should point out. All right.
I have just a question in context.
Sure.
This is Julie Taneja. Thank you for this part of the presentation. It looks like there's been a lot of improvement with the Just Health work, and so much gratitude for that. A couple thoughts. I know that HSD used to take up to 72 hours at one point to get folks switched onto Medicaid, and that was tightened up, which is great. And as I've said before, when we talked with the Department of Corrections head and another group of folks that we talked about, we work with a lot of folks who are dealing with opioid addictions, and the first 48 hours post-release from prison or jail are soaring rates of overdose death rates because people don't have access to treatment if they would like it, and may not be back on Medicaid, and may use heroin or opioids and be naive at that point to the drug, and experience life-threatening overdoses. We at Casa de Salud had been seeing a fair number of people coming in for care who had been pointed to us from other inmates in jails or prisons, or just hearing from folks in the community. And we see a growing number of people who are coming out of prison and jails, either for opioid addictions treatment and support or for primary care. And folks know of us as an organization that will take folks on without a lot of barriers, all of that. So in conversation with people, we even built it into our intake system. asking questions about if folks were recently released from prison or jail, we are still seeing to some extent folks who have had problems getting onto Medicaid, or where they feel like the prison that they came from didn't really care to do that work for them, or there was some other glitch or something, and then on the outside they had to work really hard to get on, and it would take almost 45 days to get enrolled. I think that there was a mandate or law passed a couple of years ago that prisons and jails needed to do this work, that it was an imperative for them to do this. I don't know the details around it, which is why I'm being vague. And I think during the time of COVID, this is an even bigger concern. And I'm wondering, one, during the time of COVID, if anything else is being done or can be done, and two, if there is a law or imperative, how can you all hold, or you all or whoever would be the entity, hold prisons and jails accountable for that? And then three, are there any ways to get enrollment down to less than 24 to 48 hours, making it immediate? Or is there a centralized place that we could go to if there are providers in the community or folks, families dealing with this issue where they might not know the presumptive eligibility people in the prison or whatever? Is there a centralized place? So that was a kind of a three for question.
And related to that is actually, and maybe the answer to it is, do each of these correctional facilities have the capacity to assist an inmate who's about to be released with real-time eligibility determinations if they're applying new to Medicaid, which should be kind of instantaneous? There's an issue I know with, it has to be technically when they're leaving the facility. So if you turn it on too soon, that violates, CMS gets upset.
Yep.
So I don't know if there's a way to use that, Dr. Como.
Kathy, do you want to answer any of the questions about the timing, and then I can talk about the some of the law pieces in RTE?
Sure. Yeah. Part of the biggest problem we have with the timing is not really the turning on. It's the turning on and then going from one system to another. So, and this is something we're working on. We're trying to get better data feeds. Because right now what happens is we get the information from the facility that the individual's been released. It comes into our system, our or our eligibility system, then goes to our MMIS, and then goes to our MCO. And that's where that lag takes, because those are all, they're not a single one of those is a real-time data feed. And that is the biggest issue. We do have staff that do reinstatements. So if you do have those people come into your facility and they have had Medicaid, or they thought they had it when they walked out and they should have had it when they walked out, we can reinstate them manually right away. It's not the best way to go about it, but it does allow that immediate access. And also the facilities, when they do, when they are releasing someone with high needs, a lot of the facilities will call us and say, we need to get this person ready and enrolled with this MCO so they can go into this treatment facility. And we are working with getting a new system, APRIS, which is the Victim Notification Network. And it would give us real-time booking and release information, which would move things along exponentially.
Yeah, we are really hopeful that this, the APRIS contract that Kathy mentioned, will be a significant help to us in improving timing issues. It is the nation's leading victim notification network, and so used for that purpose. And because of that, they have data feeds from every New Mexico corrections and almost every county jail in New Mexico. So we'll hope to see some improvements there. Additionally, there are some requirements around I believe, federal requirements that you were referencing for coordination or at least allowance for individuals to seek assistance with enrollment. We'll do some follow-up on that one and provide clarity. And let's see, your last question was about where could providers go? And Jane, I think you added on to that with real-time eligibility. So we've made some significant improvements to the online application system for Medicaid. So if someone's enrolling new, they can go online, insert their information, and as long as their case is not an incredibly complicated one, we are having very high return rates of real-time eligibility determinations. So those individuals can do that even from their phone if they have a smartphone, or if you all have computer usage available for folks. And the other thing I was thinking, Kathy, that might be a resource that we can share with providers. Is there some way to connect them with some of the PEs or folks who can help?
Yeah, we can
Take that.
Each clinic has their own, or each PED is employed by a clinic. I think for the most part, in most of the communities, they do want to help whoever, and they do events for us all the time. Right now, that's a little bit, impossible. We're not doing in-person enrollments, but we are doing we've allowed for phone applications because of COVID. And I think, that would be a great way to go. We also have a unit at medical assistants who can do those phone applications for people as well. So I can give you a link for or a number to call. I'm not sure how we're going to do a number because we're all working at home, but we can try and figure that out, definitely, or at least email contacts for all of my staff. So.
And our online application site is yesnewmexico.com. So that's where we have received the majority of our applications, and the Medicaid applications are done in real time. So
one more just quick follow-up thought. Not a question, but since you're all working with other states likely around how they're navigating with Just Health and transitions to the community from prisons and jails, I just want to name that I have a dream that one day federal law will allow for Medicaid to cover healthcare in jails and prisons so that there won't be any need for any of this, and that I think also care in jails and prisons will increase as a result of not having to have separate budgets and all of that for it. So I don't know if there are conversations going on at a national level about this, but it's frustrating that this all has to be created to build infrastructure to make sure that people can get seamless care before going in and coming out and after coming out.
Yeah, I think it's such a good point. And I know that there is a list of priorities from the National Association of Medicaid Directors that folks are awaiting election results to then begin starting new rounds of championing some of those items. And I think that's a great one. If it isn't already included, I will look to talk to folks about that and look at the list and maybe come back to you actually to talk further about that one and get it included. It is a pretty cumbersome process. I think that's a great idea if we could eliminate the unnecessary administrative burden there. And I said federal law as a reference point for the requirements. I did want to say in Kathy's slide, she references Senate Bill 42 that was introduced in 2015 state legislative session that has some of those requirements as well around making sure that there's allowance for submission of Medicaid applications during incarceration. So you're correct, there are requirements there, and we'll take that one back as well. The feedback is helpful. Anecdotes are helpful, but if you do start to build it into your intake and want to share that with us, it really helps us to hone in on where issues are and try to resolve them. Okay, behavioral health. I think Neil is going to jump in here.
I think I'll just stay seated, but let's go on to the next slide.
Fair.
So I want to start out by giving a shout out to one of my staff, Anita Morales, who put this slide together. I think it was conceptualized quite brilliantly. Not all of these programs that I'm going to talk about do we run out of BHSD, but quite a few of them we do. And the slide helps show how they hang together conceptually and meet people along the pathway. So this is based on something called the sequential intercept model for improving improving outcomes and helping people avoid being incarcerated for the crime of having a behavioral health problem, whether it's a mental illness or a substance use disorder. And it's based upon the idea that, well, and it's based on data, not just an idea that the way people interact typically with the criminal justice system is predictable and follows a pathway. And it identifies a number of places along that pathway that are called intercepts, where you could potentially, if you could generate high quality interventions at those intercepts, you might change the arc of the person's life and get them to needed support services rather than spending time in jails or prisons. And it's supported broadly by the Administrative Office of the Courts. Several counties in New Mexico have been working on developing a sequential intercept model of system of care for people who are engaged with, in those cases, jails, county jails in particular. Doñana County is one, Grant County is another, and I don't recall the name of the third county that I'm aware of that's been working with this. But most of these programs sit with that. So if you look from left to right, you'll see intercept 0, 1, 2, 3, 4, 5. And we do have interventions at each of those intercepts at the state level. So at intercept 0, Chief Justice Nakamura actually went to a conference and learned about the sequential intercept model and came back and set up a team, a statewide team of people trying to design ways to have to intercept at the earliest possible. So she calls it the Z team, and the Z stands for zero intercept. And we have worked with all of the judges in the state of New Mexico on understanding the interaction of behavioral health with criminal justice and the way people are treated in those things. One of the most jaw-dropping things, I was a speaker at the training for judges in March. It was the last public event I went to speak at before COVID shut everything down. And I was speaking with Grace Phillips, who's the executive director of the Association of Counties. And she pointed out that the average length of stay in county jails in New Mexico, and I don't remember the exact number, but it was under 3 days. And that includes that the average length of stay for people for whom competency issues are raised is nearly 1 year. So obviously people who come in with behavioral health issues are much more likely to spend more time in jails than people who come in without those obvious or visible behavioral health issues. So that's an important initiative. It goes forward, and we know that Justice Nakamura has now retired, but it continues to be well supported by the Administrative Office of the courts. You'll notice that at the bottom of that slide, it says BHSD Prevention Services, also at Intercept 0. And we have it's a part of BHSD. It's not a bureau actually, but it's a group of people who provide a wide array of prevention services, especially having to do with substance use disorders. It's actually also the part of state government which is responsible for trying to make sure that tobacco, for example, is not sold to minors or to people under the age of being able to do it. And it goes from that all the way through a number of projects of training and providing naloxone to reverse opioid overdoses. So, and that's all considered Intercept 0, even though there's obviously some additional parts. Intercept 1, we don't have, has to do with LEAD, that's Law Enforcement Assisted Diversion. We have pretty generous funding that's come in for this particular project. We had $1 million from the legislature that was supporting a number of small projects, and now we've been awarded from the Department of Justice a $6 million grant, which is, we're sending out RFAs next month, and we've already identified a number of locations that we want to make sure are involved with LEAD, which is diversion away from criminal consequences for substance use disorder, nonviolent substance use disorder behaviors, and getting them instead into treatment with the assistance of law enforcement. Has a good track record, and especially in Washington State, and is being rolled out nationally otherwise. I want to point in particular to BHSD issues, which are programs which include that, but also at Intercept 2, there's a specific program to assist veterans who are caught up in the court, because this is already, they're in the criminal justice system by Intercept 2. But so there's some programs to talk about pre-trial diversion, so that not waiting for them to be found guilty or not guilty or plead guilty, but before the trial to divert them to appropriate services, and to see if that corrects the behavior, and then the charges can be dismissed, and that's going forward. There's also here a couple of points where you see that competencies to stand trial evaluations. We've been making significant progress in trying to tighten up that system, because the system of evaluating for competency to stand trial is very limited legally. What it is just, do they understand the process of a trial, and do they understand the roles of the various people in a courtroom? So it's a very low bar for saying, yes, this person can stand trial or not. And nationally, there's been a movement among the behavioral health providers, especially psychologists who do these competency evaluations, to take the opportunity of doing an evaluation to also evaluate their needs for services and get them redirected to services rather than into the courtroom. So it's not just, can they understand the courtroom, but can we keep them in the community and treat them to a point where they're no longer getting swept up by the criminal justice system. So that comes at both Intercept 2 and 3. UNM also has a jail diversion program, one which is widely perceived as quite successful. One I want to point out is the San Juan Alternative Sentencing Program. It's for women in particular, and it's I'm trying to look for my note here, sorry. It provides both intensive inpatient and outpatient behavioral health services to women who are incarcerated and working through substance abuse. So it provides a continuity of care. They're identified while they're incarcerated, and provides a step immediately following incarceration to continue working on the substance use program that they initiated while they were in the county jail there. And then Susan's Legacy is actually a nonprofit organization which serves women, again, with co-occurring mental health and addictive disorders involved with the criminal justice program through intensive case management. So an array of different types of programs. I also want to point out at the bottom that the Reach, Intervene, Support, and Engage program, that last year it was known as the Intervention Demonstration Project. It's funded by the state government, state general funds through an allocation from the legislature. The first year was an intervention demonstration project because the idea was, see if we can demonstrate that starting to work intensively, collaboration between community behavioral health and the jails can lead to an absence of that falling out when they come out of jail, and instead having continued care from the moment they leave the jails. So a number of those counties, for example, provide certified peer support specialists, and you'll see above that OPRI, our Office of Peer Recovery and Engagement within BHSD, has developed a specialty of forensic peer support specialists. So it's people with lived experience coming through the criminal justice system who have, extended recovery and go through specific training. And a number of the counties use those forensic peer support specialists in quite creative ways. But one way is to meet the person being released from jail as they're being released from jail and get them to supported housing, get them to the community behavioral health provider, get them to continued medication-assisted treatment when that happens. I know that Angela talked about the increased risk of death when they leave the jails because of a gap in care there, and this is completely designed. The RISE program is not completely, but it's one of the major programs involved with it is to eliminate that gap in care and make sure there's continuity of care instead that begins while they're still in the jail, and then accompanies them back into the community and assists them in being successful in any parole or probation and Intercept 5, so that it doesn't become that recidivism circle. So that's what I would talk about right now. It's an array of programs that fit together quite nicely. We need to beef it up and expand it. Right now, RISE includes those initial counties from the IDP program. We have contracted with 8 counties to provide RISE. Most of those are, I think all of them actually are rural and frontier counties. So and we did that because we looked at what are the main substance use and behavioral health issues involved with the people in the jails in those counties, and do they have the infrastructure, the behavioral health infrastructure to provide effective continuity of care after they leave the jails. So that I would stand for questions or comments at this point for this about this.
Neil, I got a quick comment. Just as an FYI for everybody else, in addition to what Dr. Bowen was talking about with RISE, I've actually been involved with RISE in training corrections officers in a number of counties in motivational interviewing, including those peer support workers that he mentioned. But that has been surprisingly rewarding in that I found that most correction officers are very hungry for anything practical that they could use in their jobs, and they feel very ill-equipped to deal with people with substance use disorders, mental health disorders, and just how to be anything other than someone who is just kind of hurting people from one thing to the next thing.
Thank you, Brian.
I think more training needs to happen with corrections officers around like just even being trauma informed at a very small level would really help them help the people that are in their care, in their custody.
Yeah. So Brian, I have to say I'm so pleased to see you on this committee. And for everyone else, I'll just point out that Brian Sarna is a New Mexico treasure. The training he provides to providers around the state is absolutely the highest quality you can imagine. And he's committed to doing it in ways that work long term, so that there's coaching involved with it. It's not just what I call spray and pray training, which is spray them with information and pray that something changes, but it actually coaches through the changes. And Abuko, when I found out you were a chief innovation officer, I thought, oh, this is where we could get the fact, perhaps find a way to get that sustainably funded. So anyway, that's internal conversation.
Right, and I just can't wait to tell my wife that I've been called a New Mexico treasure. I'm going to tell her that tonight, so thank you.
And I love the spray and pray. Thank you, Neil.
Thanks. I think we also have a question in the chat asking would municipalities be able to apply for alternatives to law enforcement responses, such as the city of Albuquerque's proposed ACS department?
Yes, that's a good question, because I pointed out that the RISE was aimed at rural counties, but lead both Santa Fe and Albuquerque, and we're also working with people in Doña Ana County. So the municipal areas are being involved in that.
And this is Alexandria. Hi, Dr. Bowen. That question was specific to your mentioning I think you said $6 million coming in from DOJ for the LEAD project. And so I'm wondering, are alternatives that are not law enforcement, like the proposed ACS department, eligible to apply directly for that kind of funding?
So thank you for that question. And it's, you know, it's almost as if I asked you to ask it, because this is an area I'm passionate about. So unfortunately under LEAD, no, because that's law enforcement assisted diversion. But I think I mentioned 988 last time. If I didn't, I apologize. Last time that
You did.
Okay, good, perfect. So I won't go back into that, but that is everything about moving behavioral health and substance use emergencies out of the 911 system and into behavioral health care instead. So that's my hope about improving that and having alternatives to law enforcement responses become well funded. That, by the way, the 988 legislation that was passed will include a small, unfortunately too small, bump in our mental health block grant from the federal government, which is reserved to use to build out this alternative crisis care system. And we are already planning how we might roll that out. And I'm very open to suggestions from the community, including from this group. So thank you for asking that question.
Perfect. And I was going to ask a question as well, and I think you had answered it last time. It was just about, into Dr. Neil Bowen, that with the LEAD program, it was my understanding that police officers were with the person all the way through the program. And I was trying to see if there was more consideration, or if there's going to be consideration given to being more of a handoff where, you know, they're not really participating in the whole process, just kind of handing them off to mental health professionals. And then I don't know how else that would go, but yeah.
Yeah, that's a good question, and the model is kind of more subtle than just the law enforcement officer can part of that is bringing them to the kind of services which are going to help them build out that meaningful and satisfying life that everyone deserves. So, and the law enforcement officer, that continuity is to provide a touch in the community that knows this person and appreciates this person. So. But yes, there is a connection to behavioral health involved with that.
Thank you, Neil. Do we have any more questions for Neil before we transition over to Abuko? As Jane stated, Neil, you're our treasure, okay?
You're our treasure, concur. So Abuko Estrada, some of you, I have learned in my short time here that New Mexico has a very close-knit healthcare community. And so I am guessing that many of you may have known him in his previous role, and we snagged him, and we're so thrilled to have him. He's my treasure at Medicaid. And so I'm going to let him walk through this work because he has certainly championed it in a number of ways. But this was specifically to address one of the questions that you all presented us with around Medicaid buy-in as a coverage expansion option, and to let you know kind of where we're headed at this point. So Abuko, I'll let you take it from here.
Sure. It's tough to follow when labels like New Mexico Treasure are being thrown around. So, but I'll do my best. And so for this particular presentation, I'm going to give you a little bit of a background on the.
Abuko, just to set up on this though,
Sure.
The problem is we have less treasure to allocate, which makes your job particularly difficult these last few months. So,
well noted, for sure. And so for this presentation, when we're talking about coverage affordability initiatives and policy options, you can get a bit wonky with the options. And so I thought I'd spare you some of that level of nerdiness, after 5 o'clock on a weekday. So I do try to keep this a little bit high level, but there are some additional slides, I believe, in the appendix that refer to a little bit more detail around some of the options that I'm going to go over. Just to give you a little bit of background, I really start off with the challenge that we're facing in New Mexico. I think we could add what Jane mentioned as well with our budget situation here as being part of the challenge. But certainly around coverage, before the Affordable Care Act, New Mexico was in a position where, roughly 1 in 5 of our residents lacked health insurance. And with the Affordable Care Act, we were able to make significant gains, cutting that uninsured rate in half, in large part due to the ability to expand Medicaid to adults between the ages of 19 and 64, which has helped cover over 250,000 adults in New Mexico. Additionally, the ACA provided a program for premium assistance and cost sharing assistance for those who can't get Medicaid, but who are looking to purchase private health insurance through what's known as a health insurance exchange. And the one in New Mexico is called Be Well NM, if you all have not heard of it. And that program currently serves around 40,000 New Mexico residents, helping them get access to, some quality, affordable coverage where they might not otherwise have it. The ACA also offered some critical consumer protections. I'm sure, as you all hear about in the news, one in particular is the pre-existing conditions protection there, not allowing insurance companies to discriminate based on pre-existing conditions. And so it's things like that that have really helped not only improve access to coverage, but the coverage itself as well. But over the last several years, particularly since 2017, efforts have increased to chip away at the ACA, and we've seen that lead to some erosion in some of the gains. Not to mention the COVID-19 pandemic and its impact on the economy, which has led to us seeing some additional uninsured New Mexicans in the state. And so right now, we're currently at around 214,000 New Mexicans under the age of 65 who are uninsured in New Mexico. One of the top concerns, of course, before the pandemic, and I think certainly coming out of the pandemic, is the coverage affordability. Even with the access to Medicaid for some individuals, and even with the programs providing premium assistance and cost sharing assistance for those who don't get Medicaid, sometimes those subsidies just aren't enough for families to be able to afford the healthcare coverage. And then even for those who can, quote unquote, afford the premium for coverage, sometimes they get into a plan where they face high out-of-pocket costs, such as deductibles and co-pays, leaving them what we refer to as uninsured. And so New Mexico is really, I believe, at the forefront of addressing these challenges with coverage, affordability, and access among several other states. Next slide. This just gives you a picture of what the uninsured population looks like in New Mexico and the type of programs that they're eligible for. And so we worked with the Urban Institute on putting together this data for us. And we have a wide variety of demographic information, but perhaps some of the most important was the programs that people were eligible for. And so if you take a look at the chart, you see that out of the 214,000 who are uninsured, roughly about 30% of them are eligible for Medicaid and CHIP, but they're not enrolled. And so, that's an area where we can really work within the Medical Assistance Division to increase our targeted efforts to try to reach these folks and get them connected to the free quality coverage that Medicaid provides. Additionally, we have roughly about the same amount of individuals who are eligible for that premium assistance program that I referred to under the Affordable Care Act, but they're not signed up. And so, it could just be that they don't realize that they're eligible for subsidies, or maybe it's like we talked about, they're eligible for subsidies and could afford the premiums, but when they go look at the plans, they see the high deductible ones, and it totally turns them off from even buying a plan. And so, that's what the rest of this presentation is going to focus on in terms of talking about, a potential program for helping these individuals access that coverage that they're eligible for while increasing its affordability. And then on the rest of the chart there, you just have populations that aren't eligible for these programs, due to things like federal restrictions around immigration status, some flaws in the Affordable Care Act around offers of employee-sponsored coverage that don't allow certain family members to access tax credits to help them pay premiums if there's a employer offer of coverage in the family. And then individuals who just have too high of an income to qualify for any assistance. Next slide, Angela. So, and then this just dives a little bit deeper into the uninsured in New Mexico, but breaks it down by race and ethnicity to where you can see sort of where we're at in terms of, uninsured rate amongst different racial and ethnic groups. You can see here in New Mexico, we have about a 12% uninsured rate, but we do have Hispanics and American Indians who are above that sort of average here in New Mexico in terms of the uninsured. Next slide. All right. And so we've talked a little bit about the challenge and some of the background. One of the responses to the challenge is something that you all made reference to, which was the Medicaid buy-in. Sort of alluded to by Nicole in my past life. I was an advocate for 6 years with the New Mexico Center on Law and Poverty, and as part of that work, I helped in terms of leading the campaign on the Medicaid buy-in and drafting the legislation. And then they did snatch me and convince me to come over to the state side and help them continuing in on some of this coverage affordability work. And so, while I was on that other side, we got some memorials passed to have the state take a look at a study of the Medicaid buy-in, which we worked with Manat Health on to do a qualitative and quantitative analysis of a Medicaid buy-in approach in New Mexico, which was introduced in the 2019 legislative session. And it was a limited model of the Medicaid buy-in that would have allowed New Mexicans who were currently locked out of the coverage system be able to access a health insurance plan. So this includes those family glitch folks that I was just referring to, who aren't eligible to receive any premium subsidies because of an employer sponsor coverage offer in their families, those who are locked out due to immigration status, and it would have also assisted individuals who make too high of incomes to qualify for any assistance by providing something that would have been a little bit cheaper for them to pay, the full sticker price for. Some of the downsides of the Medicaid buy-in were that it was state funded only. And so, it has Medicaid in the name, but it doesn't quite leverage the dollars like Medicaid does. And so there wouldn't have been any leveraging of federal funding. Ultimately, it did not pass, but what ended up happening was there were some dollars that were appropriated to the Human Services Department to continue study of coverage affordability initiatives and putting together a plan. And that's where the rest of my work has come in over the last year that I've been with the Human Services Department. And so next slide. And so as we continue that work, we keep several goals in mind in terms of improving affordability across New Mexico. And making sure that we're identifying options that reach not only the uninsured, but the underinsured as well. And so, first and foremost, we do want to obviously reduce the number of uninsured New Mexicans, getting as close to universal access as we possibly can. We also want to address affordability challenges. We want to address them on the front end with the ability for individuals to be able to, pay for their monthly premiums. But we also want to address it at the point of care with their out-of-pocket costs, such as co-pays and deductibles. And we want to make sure that folks are getting high-quality plans at a rate that fits their family budget. And when we're doing these things, we want to make sure that we are maintaining the stability of our health insurance exchange market. It's a fairly small market, but it does provide quality access to coverage for individuals. And so we do want to make sure that we're maintaining the stability there and that it's a competitive marketplace so that New Mexicans are getting the best value for their money. And we want to make sure that we have a system, between Medicaid, the exchange, and other coverage options that is providing our healthcare system with the adequate reimbursement that it needs to be a stable healthcare system for us and the best that New Mexicans can access. Next slide. I'm sorry, my internet's a little slow, so these transitions are a little slow, but getting into the coverage affordability study, this was the second phase of work that we did with the Urban Institute. And what they did is they updated our uninsured demographic numbers. That's where we get the 214,000 New Mexicans under age 65 who are uninsured. And then they also help us look at several different coverage options. This included a range actually of enhanced premium and cost sharing assistance scenarios, which we found to be the most effective options for meeting the goals that I just outlined in the slide before in terms of boosting enrollment, improving affordability, and helping us maintain a healthy exchange and healthy healthcare infrastructure within the state. We also took a look at the basic health plan. This is an option under the Affordable Care Act for individuals under 200% of the federal poverty level. And so low-income individuals, which would be provided a public plan that would help improve their affordability. After taking a look at this, it really wasn't a good fit for New Mexico. And in large part, that's because, we already have some low premiums here within the state. And the states that really benefit from this have higher premiums and other circumstances that really make the BHP a viable option within their state that doesn't cost an insurmountable amount of funding at the general fund level. We also found that it wouldn't have increased enrollment for as many New Mexicans as some of the other options. It would have also resulted in lower provider reimbursement rates, which was a huge concern at any time, but especially during a pandemic when we know providers are working their tails off to ensure that we're safe and healthy, and we want to make sure that they're adequately reimbursed. And it also would have reduced participation in our exchange, and so would have made for a less healthy exchange marketplace, which, as I said, it's already small, and so anything that we would have done to reduce its size might have put its long-term longevity in question. And then they also looked at reinsurance, which is really just a program to partially reimburse insurance companies for certain high-cost claims. We found the results there, or the impact there, to be very, very questionable. It had very limited increase in terms of enrollment in New Mexico, and there were actually concerns about increasing the cost of certain plans particularly for low and middle income New Mexicans. And so really didn't see that as a viable option. Next slide. And as I mentioned earlier, there's some more detail about some of these options in the appendix if you want to take a look at those. And so overall, what could a coverage and affordability plan look like in New Mexico? You know, I think a couple of key pieces are reaching those individuals who are eligible for Medicaid but not enrolled. Remember, that was about 30% of the uninsured population. And so if we're able to do some targeted outreach to them and connect them to coverage, we can already make a huge dent in the uninsured and get them connected to free quality coverage that they're already eligible for. And then in addition, you know, those individuals that are eligible for coverage through our healthcare exchange, the Be Well and M, and who can get subsidies, we can help improve their affordability in terms of that coverage by providing some additional premium assistance and cost sharing assistance. And so what we could potentially look at doing here in New Mexico is to provide that enhanced assistance for New Mexicans who are low and middle income, below 400% of the federal poverty level. We can also offer some additional cost sharing reductions for lower and middle income New Mexicans, particularly between 150 and 250% of the federal poverty level. Those folks who tend to struggle the most with the high deductible plans. And the benefits from taking this type of approach that we saw from the Urban Institute study is that up to 23,000 New Mexicans could become newly insured through Be Well New Mexico. And we could improve the affordability for over 70,000 additional New Mexicans who currently purchase their coverage through Be Well New Mexico, who would be eligible but are unenrolled. And this would result in an average annual savings for families who are low or middle income of roughly 28 to 43% of their healthcare costs, which is huge. And then for those families who are a little bit higher income, they would actually see some indirect benefits as well. When you pull in more people into the Be Well and M, what you're going to do is you're going to attract younger, healthier individuals, which means you're going to improve the risk pool. And that means that insurance companies can then lower the premiums for everybody across the board. And so that has the benefit of also helping those people who don't qualify for assistance and have to pay full price. And they could see a reduction under this type of plan of 15 to 18.5% reduction in their annual healthcare costs. And so overall, what you would see is, you know, improved affordability at the front end with premiums, at the point of care with lowering copays, deductibles, and coinsurance, while also meeting our other goals of maintaining stability in the marketplace and providing adequate reimbursement for healthcare providers. And so with that, I think I'm done unless there are any questions that you might have.
Hi, this is Hussein. Thank you for that presentation. That was very, very informative, very well put together. Thanks a ton. You know, I'm learning so much by reviewing these topics and just seeing what you guys are doing. So thank you. I wanted to ask you a couple of questions in regards to improving coverage in New Mexico. I remember there was HB 278. That was I want to say that was the bill for insurance surtax last session. I wanted to hear what your thoughts were about that, particularly as it pertains to whether those costs, whether there were mechanisms to prevent the costs from being directly sort of transmitted back to the consumer.
So I'll let Abuko answer, but I think I should probably go first since
Okay.
Issues about budget and taxes and this is a premium surtax, are things that sort of live within the governor's office and the Department of Finance administration. The governor hasn't made decisions yet on her legislative priorities. We're also going to be waiting for December projections on revenue for the state. But in terms of the key thing about that bill is that the design was to basically add a tax to premiums. I'll let Abuko, he'll explain it much better than I can. That's replacing a federal tax that went away, that was repealed by Congress, that had existed under the ACA. So it's a funding mechanism. But the question is, what would you do with that funding? So there are two different parts of that, and some of that could also be a mix of, there's a lot of desire for more general fund this year, and a lot of complicated issues about that. But in terms of the structure of it and kind of the affordability fund it would have created, Abuko, go forth, and you can explain it better than I.
Oh, I think you did a great job there, Jane, already. It really would just be replacing the federal fee that was repealed on health insurance plans, and basically putting it into place at the state level by increasing our already existing premium insurance surtax. And so that bill would have taken our existing surtax from 1% and increased it to about 3.25%, and put that funding into a healthcare affordability fund. And at the time, it didn't have any particular options for how that money would be spent. But I'd say, given the study that we've done, if such a bill were to be implemented by the legislature, and they did create a healthcare affordability fund, certainly, I think the options that I referred to around premium assistance and cost sharing assistance could be some of the things that type of bill could help fund.
And as I recall, Abuko, and again, some of this was in the public record of amendments, and then there was a negotiation, but it never got through Senate Finance Committee earlier this year. But there was always a certain amount of the funding that would actually go to the general fund, and there was a little bit of a back and forth about how much would be general fund and how much would be in this affordability fund that the Human Services Department would be overseeing.
That's correct.
Which gets to your question, I think, about how much of the money could flow to the individuals, and so that would be kind of detailed in that legislation. You sound like you had a follow up. Go ahead.
No, that actually was the follow up. Were there any mechanisms to sort of keep that from just being passed on directly to the consumer? The increased premium tax that the insurance company would pay, being just directly.
I see.
But I didn't know if I wasn't certain if I was reading it correctly. But I could just see that being, well, we're going to pay this amount due to the premium. Well, we're just going to increase rates X amount. Mm-hmm. And I just kind of looked at it like that, and I was wondering if that were to pass, if there was anything in there to keep that from happening.
That's actually an argument that was made against the bill. But I will tell you, this year, the superintendent of insurance, the question was, because it was repealed this year, great, were we all going to get savings in our health insurance premiums? And the first proposals from the plans, to offer individual plans, were very, very high. And the superintendent of insurance basically said, no. And you have to come back with, and there was a sense that perhaps it wasn't being passed, the savings wasn't being passed on, but now what is going to be offered in the exchange starting on Sunday, actually the premiums are going down. They'll be less expensive this year. And so the superintendent played a critical role in that.
Right. And I think, just to add on to that as well, when we're talking about coverage within the health insurance exchange, if the rates were to increase the infrastructure around subsidies that the federal government provides, would actually absorb some of those increased costs. And so the consumer wouldn't actually necessarily see the increase to their premium and what they pay on a monthly basis. The federal government would actually end up paying a little bit more in terms of assistance to help provide that.
Okay, awesome. Thank you, guys. And if it's okay, I don't want to hog it, but I wanted to ask 2 more questions, if that's okay. One was for Mrs. Nicole Como. I appreciate you giving the goals for the 1115 waiver for substance use disorder. I was curious what some of the strategies were for that. And if you would be able to either talk about them here or send us any information in regards to that. Or if I was looking as a consumer, where would I find that?
Yeah, that's a, make sure I'm unmuted here. That's a great question. So I think we can do that, send that as a follow-up if that's okay with you, and send you some of the strategies. I do want to make sure to share with you all the last section of the presentation. So we could send you the strategies as a follow-up, and then the waivers are all posted on the Medicaid website. But this is one of our areas for improvement. It is not very simple to navigate. So we'll be happy to follow up with you right after this with a link to where it is as well. But we've got some shorter summaries we can share. And then did you have one more that you wanted to ask?
I'll let you guys I'll let you guys finish this, and then I'll ask, if that's okay.
No, okay. I was gonna say, jump in. We want to answer questions. The strategies, which would take us a while, though. Okay. So I'll jump in. And
I don't know if we want to address the questions really fast that are in the chat before we move forward.
Oh, new ones came. Sorry. Do you know if there is a plan to reintroduce the Medicaid buy-in bill that was introduced in 2019? Not that we have been made aware of the Human Services Department. I think, we are certainly doing our best now that Abuko has done all this great work with the Urban Institute to notify the legislature about some of our findings and about some of these other coverage options. So we just presented about this to the LHHS committee a couple months ago here, and let them know about this. And I know that there'll be continuing conversations. Jane, have you heard any conversation about that?
I have not. It's not Health Action New Mexico, which was a major sponsor, has other priorities this year, including one related to the exchange, but not that. I think one of the challenges is the cost per person. I mean, it was really challenging in the legislature because there was no federal matching funds available. So everything was going to be all out of general fund. And that was an issue. Number two, it also was going to be a significant new program. It really wasn't Medicaid. It was going to have to be a new kind of option made available, run by HSD. There would have been significant administrative costs to that as well. And there were concerns about identifying the people that would be eligible. This family glitch thing is really weedy and complicated. And so there was just a whole kind of array of issues that came up. And there were some concerns that we had about some of the actuarial analysis that had been done, which was done very late, kind of received it the first day we were in the office that January, I think, and it was still not quite. And so there were concerns about the estimates for the costs and how solid they would be. So.
Thanks, Jane. And then the next one is about projected cost savings to the state if we insure more people. We do have some of those numbers that we can share about uncompensated care costs, a little harder to project the overall cost savings to the states, but we will take that one back and share data that we do have and then continue to look for other opportunities. By not including 65 and older individuals in the coverage stats, do we exclude undocumented elderly in our numbers? Abuko, I'll let you think on that one while I take this last one. Also, for the uninsured Native Americans, do we include people who access IHS care without secondary insurance as insured? Referred care is not always covered by IHS. So IHS coverage, we do not count as coverage. It doesn't meet the minimal essential coverage requirements outlined by the federal government. So we don't include that. Those individuals would be counted as uninsured if that's their only source of coverage. Abuko, do you want to take the second one, the other one I mentioned, or take it back?
Sure, and yeah, I mean, I think the simple answer is that they are excluded from those numbers because we are excluding those individuals who are 65 or older in the uninsured numbers, and that's just due to a lot of the issues with access to Medicare, as well as just census issues regarding that population, and so the Urban Institute was really only able to focus in on the non-elderly population.
It's an interesting, does anybody know whether the same, I think Medicare is not available to undocumented immigrants, but the ban in Medicaid for people who have who are legal residents, but have not been in that status for 5 years. Does anyone know if that's a Medicare restriction too? I assume that that's not as much of an issue because people at that age probably have been in the country for that long. But it's, I just made a note. It's a very good question.
Mm-hmm.
Maybe that's something we can get a follow-up on as well. Thank you.
Yeah, I just wanted to note that a couple of us have a hard stop at 6, so if it's okay, can we proceed to the next set of slides?
Yes, please. Thank you.
Okay, go ahead, Nicole.
Thanks, Angela.
Sure.
Okay, I'm gonna, as you all can imagine, this topic of racial justice and equity is certainly something that a lot of us are focusing on in a lot of different areas. So I was asked to speak about some work here in New Mexico around reproductive health equity to National Association of Medicaid Directors. So this presentation was a little bit longer. I'm going to try and do it quickly because I do have a hard stop at 6. But if any of you have particular interest in this area or have follow-up, this is an area I'm passionate about in particular, so I'm more than happy to have some further conversation. So before I go into the details of the efforts, I just wanted to call out some numbers that highlight why this is so critically important here in New Mexico. So first, as you all may know, we have the second highest percentage of people in poverty in the country at 19.2%. Almost 50% of the state's population receives their health care through Medicaid, as I already mentioned, and 72% of all babies in New Mexico are born onto Medicaid. That is the highest number in the country and an unbelievable statistic. At 48.8%, New Mexico has the highest percentage of Latino and/or Hispanic inhabitants in the US, with the exception of Puerto Rico. And we have the third highest percentage of American Indian and Alaska Natives at 14.9%. So again, calling out those two populations in particular here, just because of the points we're going to make, but you saw some of the other statistics around our uninsured population across different races as well that Abuko mentioned earlier that I think are relevant to this conversation. So I want to point out next that we have the 7th highest teen birth rate in the country, the 7th highest teen birth rate in the country at 25.3%. The birth rate of Hispanic teens is 28.9 for every 1,000 young women, whereas for Caucasian teens, it's 13.2 for every 1,000 young women. The statistic that I think is just an incredible trigger for us here to certainly continue to take action in addition to what has already been done is that American Indian and Alaska Native teens have the highest teen birth rate of all races and ethnicities across the country at 32.9 per 1,000 teen women. All that to say, we have a very large population who is clearly still struggling with reproductive health autonomy and disparities in access. So there have been some really critical steps here in New Mexico that have worked to address this. So next slide, please. Thanks. So this is a complicated slide, but bear with me, I'm going to walk you through it. As you all can imagine and know, I'm sure, teen birth or adolescent birth is strongly associated with greater inequality in this country, and unplanned pregnancy or birth could certainly alter the life course of an adolescent mother and her partner, hindering opportunities for education, meaningful employment, and the kind of environment they intend to raise their child in as well. Long-acting reversible contraception, so LARC, as we refer to it, methods have not only been proven to be the most effective form of contraception, but have also been confirmed to be safe and effective when used by adolescents. So despite knowing that this is one of the most effective strategies we have, LARC usage in teens remains at actually only between 2 and 3% nationally. There's been an incredible large cohort study where when barriers to contraception, including access and cost, were removed, the majority of young women between 14 and 17 chose LARC as their method of contraception. So having no issue really with addressing cost here as much, the team set out to tackle access issues. So payment challenges related to LARC utilization exist both on that fee-for-service side that I spoke about earlier, and also on the managed care side of the program. So for example, in the inpatient setting, the use of a single prospective payment for labor and delivery services, so a bundled up payment for those services. I know we've got a lot of providers, so I don't probably have to go into this, may not sufficiently address the additional costs that are associated with the provision of LARC. Another example here around payment issues and access issues is that there are significant advantages to providing LARC immediately after delivery while women are still under hospital care. So those are a couple of the items that the team started working on, and what you'll be able to see here in the graph are the policies that were implemented. So since 2014, there are pretty significant efforts that have been underway. Get myself aligned here since I'm trying to speed this up. I'm off base in my notes. Okay, so the bar graphs that you see there actually show the numbers of LARC usage among Medicaid women from the years 2010 to 2018. And what this demonstrates is some pretty incredible outcomes of these interventions. So with the increase in LARC usage, the green bar graph, you can see non-teen Medicaid women starting to utilize that long-acting contraceptive in higher numbers. Sorry, I'm trying to get myself oriented in my notes here. So if you look across the bottom of the graph, you can see where the interventions occurred. So initially there was the elimination of an age limit and an expansion of family planning Medicaid that allowed for better access to these services. Then later in 2013, the team made efforts to unbundle inpatient LARC, which was one of those access issues that I just addressed previously, and payment issues. Then in 2014, the state chose to expand Medicaid, creating even more access to a larger number of low-income adults. And then more recently, in 2016, the team unbundled LARC from FQHC's encounter rate. And then most recently in 2019, which isn't yet captured because our data is still incomplete, we increased rates for LARC, putting us now, I believe, at 4th highest in the country. So what you can see here with the green bars is the increase in utilization for Medicaid members. The purple bars are the number of teens who began using LARC. And then what you can see with the blue line is the decrease in Medicaid births, that top line there, Angela, sorry. The decrease in Medicaid births that corresponds with the increase in LARC usage. Additionally, and we'll see this better in the other graphs as they break apart, but what also happens is an increase in women who are indicating that their pregnancies were intentional. And that is that red line that you start to see creeping up there. So when we go to the next slide, it breaks these apart a little bit better. Okay, so the two colored bar graphs show the downward trend in New Mexico Medicaid births associated with each of those 4 interventions and highlight the trend in our most populous county, as you all are aware, in Bernalillo. The next slide, Angela, if you can move me forward again, I think is where we really start to be able to show what interventions in the Medicaid program can do to create, changes in that equality in access and autonomy around reproductive health. And then again, obviously can be extrapolated to other areas, but I just think this is such a great example of how you can make changes to the Medicaid program and truly, see changes in behaviors and individuals' lives. So the graph on the left illustrates the trend in the higher portion of Medicaid women who are reporting pregnancy intention. And as you can see, interestingly, the number of women who are reporting pregnancy intention in Medicaid is actually surpassing those who are reporting pregnancy intention for the overall population of women in New Mexico. With the interventions that have been put in place, we are now approaching the national average of 59%. We are at about 55%, which is incredibly encouraging given some of the other health statistics in the state and the numbers that I mentioned at the beginning. The graph on the right shows that although the trend in the proportion of Medicaid births remains stable, we are actually seeing an increase in the proportion of births, again, with mothers reporting a pregnancy intention. Okay, thanks, Angela. So we'll go to the next slide. So these are great steps to allow folks to, women and partnerships to control their own reproductive health. And then beyond that, we're taking some next steps to figure out how we continue to help these populations when they do have infants at home, but have other challenges. So the home visiting program that was established under the Centennial Care Program, so the waiver that we have been speaking about, has been going on just for a short time now, over a year. And the results from one of our MCOs are what are displayed here. And they are also incredibly encouraging. So let me pick out the highlights here to talk you through as we're running out of time here. I know we're 2 minutes over, but what the graph essentially shows is that with the intervention of home visiting, so helping mothers and partnerships with having folks come into the home and do education with them, provide services, access to community resources, that we saw a significant reduction in those infants that were admitted to the NICU when born. So you can see the green bar is those families where they were participating in the Centennial Care Home Visiting Program, as opposed to those in the yellow bar who chose not to participate. This effort involves about 171 women overall at this point. So the next section of the bar graph that again just is incredibly encouraging is that 1.6% of those babies were admitted to the NICU who participated in the program, as opposed to 10% of those who did not participate. And they were admitted for prematurity and low birth weight, statistics that are often disproportionately associated with both adolescent births and then also still disproportionately associated with people of color. And then finally, the last graph is a next step to those in the NICU, but talks about neonatal abstinence syndrome. Unfortunately, we did not see any significant difference in those babies that were born with neonatal abstinence syndrome across this intervention yet. But sorry to go through that so quickly. There's a lot of information there and more that we'd be happy to provide. But again, the Medicaid program touches so many individuals in New Mexico. We're so excited about the work that you all are doing, and we hope that we can be a great partner to you all in utilizing that access that we do have to really make some significant changes in the state.
All right, thank you very much for staying on with us a little past time. We really appreciate it and all your expertise. So the partnership is developing, and this is ongoing conversation that we hope to have amongst all of us. So thank you again for your time and for the great information presented. If I could just get a copy of that, and I will be sure to share that out in the notes to the subcommittee members. And anything else you'd like to add?
Also, please don't hesitate to send us questions.
Yes.
That came in as a result of the last set of slides. I see some chats coming in, so we'd be happy to send you responses to those or any other questions you all have. I was just so happy to have such a robust conversation and discussion with you all.
Us too. Thank you very much. All the partners joining from HSD. Have a good evening, everybody.
Thank you.
Thank you.
Look forward to talking soon.
Can I mention a couple of things to the subcommittee? That's
sure.
okay?
So if other people need to drop off, that's fine. And now's fine to do so. Thanks.
Okay, perfect.
I'm going to stop recording real quick.